Okay, so this is the review for chapters 11, 12, 13, 14, and 15. So it is a lot of information, of course, but a lot of this is going to come together as you do more in the hands-on lab. It kind of helps pull all of this information. You know how once you read something and you review it, but once you get hands-on, it really starts to kind of click, right? I have, again, like I do with all the lectures, pulled some of the key terms from the NHA so that we make sure that you know some of those key terms and things that are specific that NHA is looking for. So the first thing we're going to talk about briefly here is just non-blood specimens and patient preparation, because depending on where you work, you can be collecting specimens that are not just blood. Now, usually these are specimens that you're just giving your patients instructions on what to do, how to do it properly, right? So that the collection is done properly, the transportation and the handling. So one of you guys can type it out or say it. Is there one that maybe when you think of a non-blood specimen that's being collected that pops into your mind first? Maybe the most, I don't know if it's the most common, but to me, I always think of one first. What's an example of a non-blood specimen that you may be collecting, even where you guys work? Urine, exactly, Bonnie. So there's also stool, sputum, semen. So basically, in all of these instances, like we said, you're responsible for giving instructions on how to properly collect, handle, and transport. Now, these are the most often ones that we're going to come across depending on where we work, like an office setting like you guys. Maybe you work at an urgent care or just a lab. NHA also mentions two other specimens that you would not be collecting, that we do not as phlebotomists collect, but NHA just wants you to be aware of these two specimens. These are typically collected by a physician. This is cerebrospinal fluid and amniotic fluid. Um, Cerebrospinal fluid is basically the liquid that surrounds our brain and spinal cord. You're probably familiar with that. This is collected to rule out different disorders, diseases, sometimes infections as well. So, just something to be aware of. And then, as you guys may know, amniotic fluid, of course, is the liquid, the fluid that surrounds the fetus inside the sac and the uterus. And samples can also be taken from the amniotic fluid to look at different diseases or conditions that the baby may have. So let's talk. Bonnie mentioned that urine is like the first one that kind of pops into our minds. So let's talk a little bit about urine specimens, because it is, like I said, if not the most common, it's one of the most common of all laboratory tests that we do. Is the routine urinalysis. Routine urinalysis, a lot of times we're ruling out, is there a urinary tract infection? These instructions are not complicated. You basically give them the cup, tell them to clean themselves off appropriately, and they're going to go into the sample or into the specimen cup and then close the lid and give it to us to process. There's something called, oh, before I go there, hold on. A urinalysis typically, because of this, is typically a waived point of care test, right? That we can do in a lot of different settings. When we do a urinalysis, Bonnie or Kimber, have you guys ever done a urinalysis there? I imagine you probably have. Maybe if you guys have the little reagent sticks there to use. Not yet. Okay. So maybe something that's coming to the office, possibly. Oh, no, that's okay, Bonnie. Maybe I wasn't clear in how I asked the question. Yeah, so a lot of doctors' offices, urgent cares, a lot of outpatient labs will have the ability to do a urinalysis. And all that, once we've got that specimen in the cup, we use what's called a reagent strip that we're going to dip into the urine. And if you guys have seen them before, I'm sure, or a lot of people have. It's the little squares that once you dip it into the specimen, they're going to change color, and that's like when we look at the bottle that they came in as our key to see what it's telling us, right? And so some of the things we're going to see on a urinalysis is going to be, let me see, we're looking at the pH, the specific gravity, is there protein in the urine, leukocytes, hemoglobin, um, And we're also looking for the color and the clarity, so the appearance as well. So sometimes that can be really helpful. So yes, those reagent strips tell us most of what we need, but we also still have to use our observation, um, our eyes to see it and report on that as well. Let me see if I was going to say anything else about that. Um, let's talk a little bit more about some of those tests that reagent strip is testing for. But before I go into that, real quick, I did want to mention the term random urine. I don't know if you guys remember reading about that in your text or not, but that's basically typically what a urinalysis is. It's a random urine. So that means it can be collected at any time of day. It's for screening purposes, and there's no preparation necessary, right? You don't have to um, the first urine of the day. I'm trying to think what else might be a preparation, but it's a random urine. Anytime is acceptable. So let's talk a little bit about some of those things that we're testing for on a urinalysis that will show up on that reagent strip. So we've got pH, which, as you guys know, is a measure of acid and base balance, right? Specific gravity. That's a measure of how concentrated our urine is. So it tells us if our kidneys are functioning well. Um, because there is a normal reference range for specific gravity that shows us that our kidneys are functioning properly. They're able to balance their water content and excrete waste appropriately. So if that specific gravity is off or getting off or way off, then that's going to be a preliminary screening that something may be going on with the kidneys. Hemoglobin, of course, as you guys know, is the red oxygen carrying portion of the red blood cells. So if there's blood in the urine, that's going to be detected on the hemoglobin, or the hemoglobin is going to be detected. Ketones. Have you guys heard of ketones or know what ketones are related to? Usually, when we think of ketones in the urine, um, anybody know what disease we might think of first? It's not the only thing that ketones tell us, but it's one of the big things. That's all right if you don't know yet. So ketones are basically, just so you know what ketones are, they're acids that form. That's a ketone is an acid that forms um, when fatty acids are broken down in the absence of insulin. So when I say insulin, of course, we're going to start thinking about diabetes. So if the body doesn't get enough glucose, so sugar, glucose, and it doesn't have that glucose to burn for our energy, right? So we get glucose, it's burned and broken down to use as energy. But if we don't have enough glucose, our body starts to burn the fat instead because it needs something to burn for energy. So a very high level of ketones can be a sign that somebody is in diabetic ketoacidosis or DKA. This is a complication of diabetes. So if these levels are very high, this could be an emergency situation that can be life-threatening, leading to coma or death even if it's not addressed right away. And that's something that we need to know. Somebody that comes in ketoacidosis is going to not look and feel great anyway. But if we do a urine to just kind of rule some things out and we see those high levels, that's going to give us a big indication of what's going on. Again, anything on this urinalysis is a preliminary means of diagnosing something that's going on. It's not necessarily a definitive answer, right? The other thing that we'll see that I want to make sure you're aware of on the reagent strip is bilirubin. So bilirubin is a yellow, it's kind of that yellowish orange. Bilirubin is a result of our hemoglobin breaking down. Okay, the breakdown of our hemoglobin causes that yellowish orange color. It's a normal process of when our red blood cells break down. But if we have bilirubin in the urine, it can be an indication of a liver issue like hepatitis. That could be because there's a blockage of structures are blocked, so the bile is not being able to go where it's supposed to. So basically, it can be an indicator of a potential liver issue. So those are the main ones that I want to make sure you guys are familiar with on the urinalysis and the reagent strip and kind of have an idea of what each of those is showing us and what they're potentially, what a couple of them are potentially indicating issues with. Does all that make sense? That was a lot of information in a short time. I mean, obviously you probably have to study and review it, but just want to make sure there's no questions in the immediate moment. Okay. All right, good. So we talked about urinalysis, right? but there's also urine cultures. So that's a whole other thing, right? It's still a urine test, but there is special preparation that needs to be done to make sure that we are growing. Because if we're doing a culture, we're trying to grow microorganisms so that we can identify what's causing the problem specifically, right? Because if we know what specific microorganism it is that's causing someone a problem, like a bladder or a kidney infection, then we know, okay, if it's this microorganism, we know exactly what antibiotic we need to treat that, to get rid of it quicker and efficiently and completely. Um, and that's actually, I jumped ahead a little bit. The culture is the actual growing of the microorganisms. The sensitivity is then to follow up by saying, okay, we cultured all these different germs. Now we're doing the sensitivity. And what that means is we're going to try different, antibiotics to see which one is most effective against what we just grew. Okay. So a culture happens first and then the sensitivity. So you're going to see it often ordered as culture and sensitivity. So I talked about special preparations for these. That's different than, say, just your random urine analysis, right? Um, the urine for this test has to be clean catch midstream. Or if we're in a hospital setting or a nursing home setting where someone has a Foley catheter, we can also collect it from the catheter in a certain way to prevent contamination. But let's say we're doing the clean catch midstream. So this is when we will instruct the individual to clean their peri area with the provided wipes. Any guesses why we have them clean the peri area and then catch it midstream? How that might be helpful, right? Exactly. So and more specifically than that, yes, we're wanting to avoid microorganisms that aren't necessarily in the kidney, in the bladder, that might just be on our skin, right? Or a surface that if we touch it. So we're cleaning off any surface microorganisms that would contaminate our sample and help us, or not help us, make it more difficult to isolate the actual microorganism that's causing the problem. Um, does that make sense, or any questions on that? Or on the differences between urinalysis and culture and sensitivity? Okay, great. Let me see if there's anything else I put on my notes I don't want to forget. Mm. Okay, so a few more different things about urine samples. You may or may not yet have heard of a 24-hour urine. This is a different type of urine test that you need to just at least be familiar with. This is typically done when we need to assess the function of the renal system, not in, and we need more time. So how is that whole renal system working? We're going to do a 24-hour urine. What you'll see if you're working in a hospital setting is that that person's going to have, uh, at least usually in ways I've seen it, they'll have like a basin, a big basin filled with some ice water sitting next to their bed, and then they have the urine for the whole day in a special jug there to be kept on that kind of slurry, and you're collecting every single urine for the full 24 hours. So that gives the ability to do more in-depth testing and see how is that whole renal system really functioning throughout the day. And that can help be, again, it's a more definitive test on overall renal function. It can tell the doctors more on what's going on. So you may hear or see a 24-hour urine collection. Yeah. So Bonnie, so you had to do this once for kidney stones. Anything in particular you remember about, maybe, and I don't mean your personal experience necessarily, but like the actual process of the 24-hour urine that stuck out to you? Anything that you noticed that the nurses or the NAs did, or needed to do that I haven't already mentioned? I'm trying to think back if there's anything else. Sent out to like a reference lab, like outside the facility. Is that what you meant? Or just like at the end of the day, they sent it out to the lab? Oh, so you did it at home. Oh, well, that makes sense, of course. So yeah, any instructions that you remember getting that I haven't mentioned to do it at home? Because in my personal experience, I'm typically doing these in the hospital setting. Um, is there anything else at home that was important of note? The cleaning, yep. Anything else? Did you keep it? I am curious, over the 24-hour period, where did you store the sample as you were collecting it? Room temp. Okay. All right. And so that's actually a great point too, though, because um, as we know, there's preparations, and when we get our initial lab requisition, we talked about this in the last lecture. We're always reading our preparation and our storage and our handling. If you ever have a question about it, always ask. So just because in my experience, I usually keep it on a slurry at the hospital. If I were to send someone home and saw that room temperature, that's a great example of when you say, well, let me just check with my ordering provider and just make sure that this is how they want this order carried out. Because if it's something that you're used to doing a certain way and then all of a sudden it's different, always check. Right? There's nothing wrong with a question to make sure that it's done correctly. And in this case, obviously room temperature was the order. And so that's great. But that was a great point to be made there. Um, So I have a question. When we are collecting, let's say we're collecting a urine specimen from a patient in an outpatient lab setting, am I going to label the lid or the cup? Does it matter? And if it does matter, why? What would be the difference? We may have talked about this before in another lecture too. Can't remember. But where do we want to label when we're collecting a urine sample or a stool sample? Label the cup. Exactly, exactly. Both of you are correct. Because the thing is let's say this sample gets to the lab, my urine or stool sample or whatever, and I've labeled the lid, which you think would be harmless, right? But let's say that technician in the lab removes the lid, sets it aside. They turn around and someone has pushed the lid away from the cup, and then you've got a table full of some samples and you don't know which lid, you can't say with 100% certainty which lid went with which cup. That's a problem. We need 100% certainty, right? We don't want to diagnose somebody with, parasites and then treat them for that if they don't have it, just as an example that popped in my head. So we always want to label the cup. Now, if you label both, that's fine, but always label the cup because it's going to obviously stick with that specimen better than the lid would. Now, in general, I know Bonnie said room temp when she had her personal experience with having to do a urine sample at home. But in general, if the patient is instructed to collect a urine sample at home, the urine should be stored in the fridge if it needs to be stored. But ideally, we're saying bring it to the lab as soon as possible. So get your urine sample, bring it to the lab as soon as possible. If you do have to store it for a short time, keep it in the fridge. That kind of preserves some of the parts of the sample that we need to test. We also want to tell our patients, if we're working in an outpatient lab setting and they're collecting a urine or a stool or whatever, we need to make sure to tell them to label it as well with their name, their date, that they collected the sample, and the time, because that can be very important in certain circumstances. So just always be in the habit, if you're sending patients home with sample collections, name, date, and time of collection. If a fasting
I have a
urine is
question.
ordered, yeah, go ahead.
Was it that if like a patient was bringing it in but couldn't bring it in immediately, was it that it could be stored in the like refrigerator? Was it 12 hours or up to 24 hours?
Usually it's up to 24 hours for urine. Um,
Okay.
that could be one of those things where you want to get clarification from your particular facility or doctor, but in
Mhm.
general, urine can be up to 24 hours.
Okay, thank you.
Okay? All right. Um, um, oh, fasting urines. So sometimes a fasting urine is ordered. So of course that's going to be first thing in the morning, as soon as somebody wakes up. So you want to, in these cases, the particular thing you want to remember about a fasting urine is to tell the patient to pee right before they go to bed, and then collect the specimen immediately after waking up. And again, if they can't the sooner they can bring it in, the better. But if they can't, do that fridge. Um, so, okay. So that kind of covers the highlights of the different urine specimens and testing. Do you guys have any questions about that? And if not, we'll move on to a little bit about stool specimens. And Kimber, that made me think of something when you just asked that. The urine specimens and Bonnie's comment too, like when we do a drug screen, it kind of depends on the test too, of course. So when we do a drug screen at work, for example, if we have to send it off for a reason to get, tested, we can put it in the little drug screen box, which is outside, on our outside of our office building in a locked box. And those can be in there for up to 24 hours. And that's obviously not even necessarily room temperature. Now it is insulated to control the temperature to some degree, so it
Mhm.
kind of varies again based on the test. But I do know for sure that the refrigeration of a specimen, urine specimen, slows down the deterioration of that specimen itself. So that prolongs it a little bit better, makes that sample better. But it also depends on what they're testing for, right? So if it's drugs in the system, it might, and I would be lying if I said I know the exact amount of time for everything and the deterioration rates of everything. But the deterioration rate of some of those drugs that they're testing for in a drug screen might be longer or slower than, say, um, you know, um, something that we'd be testing with reagent strip on a urinalysis, for example. So anyway, we'll move on to stool specimens. If you think of any other questions about those, just let me know. Um, so there are different types of stool specimens that can be collected and tests run on them. The most common is for fecal occult blood. You'll see that abbreviated FOBT. That is basically looking for blood in the stool, right? And it's specifically looking for blood because you can see if someone has bright red blood in their stool, you can visualize that. But sometimes there's blood that we don't see. So that's the fecal occult blood. Have you guys, I don't think you've gotten to it yet in lab, but have you guys looked at or done the guaiac cards yet in skills? And you might not have, and that's okay.
We have not.
Okay. Have you guys ever seen them in your office? I don't know if you guys have those in your office, the guaiac cards.
That I'm not sure of. The only thing that I've seen in our office are the hemocoat cards.
Gotcha. Yeah. So these are, it's probably, is that, it's either the same or similar. It's where you basically you get a stool specimen, a smear of it on the card. You drop the solution onto it, and it's going to turn blue if there is blood in the stool. These type of tests, this guaiac card is often done to help with preliminary early detection of things like colorectal cancer, polyps, or commonly just looking for is there some sort of bleed in the GI system? Because if there's a bleed in the GI tract, especially if it's further up, you're not always going to see that bright red blood. So it's that older blood that you're not going to be able to see with your eyes, so that you need to detect it somehow, right? So that's what these guaiac tools or guaiac cards are for. So a couple things to remember if we're instructing our patients to collect a stool specimen at home, we want to tell them a few things. We want them to avoid getting urine into the container as much as possible or at all. We do send them home, of course, with a collection device for the toilet. Usually we refer to these as the hats. You guys know what I'm talking about when the toilet hats that go in there.
Yes.
Um, hold on one second. Sorry, give me 1 second, you guys. Okay, so sorry about that. Um, what was I saying? Oh, the hats. You guys know what I'm talking about? Yes, and Bonnie said yes. Um, we also, in addition to the hat and not wanting to get urine into the specimen, we also want to avoid getting toilet water in there. So you don't want somebody to go into the toilet and then collect the specimen out of there. That's why we do the hats and or some sort of collection device for them. If the specimen is specifically being tested for parasites, we do not want to refrigerate it, but rather we need to return it to the lab immediately. So that's something important to remember about that specific, if we're testing for parasites, don't put it in the refrigerator. Um, and going back real quick to the fecal occult blood testing, if we are testing for that, there's a few precautions for this one as well. We don't want patients to eat red meat. We want them to avoid citrus fruits and raw vegetables. And we don't want them to take vitamin C or aspirin for 3 days prior to specimen collection, as these can all alter results and give false positives. All right, so let's talk a little bit about sputum specimens. Um, these are done, when I say sputum, I mean, we're hacking up out of the bottom of our lungs. When we do sputum specimens, it's usually for one of two reasons. We want to confirm what microorganism is in the lungs causing the infection, or we're doing a sputum specimen some point during treatment to see is the treatment we're giving, excuse me, effective, or do we need to change or increase or whatever. So again, sputum specimens, what's going on in there so we know what to treat it with, or we've been treating it, is it working? Um, Let me see what else I want to say about this. Okay, so I think this is a test question. So sputum testing is most accurate if it's collected first thing in the morning before you have anything to eat or drink. And that's really important. So if I'm instructing somebody, that's going to be really important to tell them, right? It's going to be the most accurate. The other instruction we give when we're doing sputum specimens, and I said a second ago, go from deep in the lungs, because that's really important. So what we want to tell our patients if they're doing a sputum is to take a really big, deep breath. Sorry. Big, deep breath and cough not only forcefully, but deep. Try and get like a really deep cough. Think about getting it from the bottom of your lung. And then, of course, you're going to expectorate or get that sputum into the container. You want to get it from the bottom of the lungs as best you can, and you want to avoid a lot of extra saliva. We really just want as much of the sputum as we can get and not a bunch of spit. These specimens also need to be delivered to the lab as soon as possible. All right. Semen specimens. The thing to remember about semen specimens is that we're, of course, responsible for instruction, handling, and transport, just instructions. The main one being that we need to protect these specimens from excessive heat or cold and deliver to the lab within 1 hour of collection. Um, Another way of saying it is basically keep it away from extremes in temperature. We want to keep as close to body temperature as possible, which is why if we get it to the office within 1 hour, that's going to be what we need to do, but also less likely that it's going to get those extreme temperatures. So you don't want someone to, um, collect the specimen and on their way to the lab, stop at the grocery store when it's 90 degrees outside and leave the specimen in the car, right? So just make sure we're instructing patients about the extremes in heat and the timing of this one. Some other non-blood specimens that we might do, glucose tolerance testing. If anyone's had a baby or known anyone who's been pregnant and had to do this, this is done during pregnancy, for example, not only, but during pregnancy to check for gestational diabetes. This is a test, it's seeing if our body is metabolizing sugar as it should. So there are some timing specific requirements for glucose tolerance testing. And this is actually in your book. So I'm not going to go review over all of these right now just because I don't want to run out of time. Just review in your text the specific instructions for glucose tolerance testing. Let's see. Postprandial. I want to make sure you guys know what that word means. That basically just means after a meal. Postprandial, after a meal. Sometimes that can mean 2 hours after a meal. Sometimes it might mean 4, and it will be specified on the order. And if for some reason it's not, again, that's where we're asking questions to our ordering provider. There are other tests like throat swabs, nasal swabs, nasopharyngeal. Now, those were talked about in the lecture and the test. So just in the text, excuse me. So just review over those so you're familiar with them. One that I don't know if it's in the text or the lecture was the buccal swabs. That's the inside of the cheek. One of the most common reasons that a buccal swab is done is for DNA testing. Um, Saliva testing. This is, of course, collecting saliva. These can be done, let's see, hormone testing sometimes, drug, alcohol levels. That's sometimes what we're doing saliva tests for. Um, it says fecal test, but I mean, we talked a bit about stool specimens, but um, again, I don't know if we talked about parasites, blood, also just different infections that are present in the stool as well. That would be other reasons to do fecal or stool tests. Um, a lot of these tests, like the nasopharyngeal, the throat swab, the nasal swab. A lot of these are point of care waived tests. Um, and that's because we talked about a little bit about waived, I think, in the last lecture. Is because these tests are easy to do, easy to follow instructions. They have the controls built right in. And if you have oh, and like expiration dates, all of that's just built right into the point of care testing. Again, if something were to become up false or incorrect, it's usually things with the more minimal risk to them. um any questions about any of those? I have a few more things to say about these tests, but any questions so far? Are you feeling okay with all this content up to this point?
I just have one question. I kind of missed
Yeah,
it. You
it's
said
okay.
that the sputum testing, you said that it was going to be a test question. You said that it was done first thing in the morning.
Yeah, before eating or drinking.
Okay.
Yeah, I think a lot of people miss that question because I don't, maybe because they just think early in the morning, but they don't think about before eating or drinking. But ideally, it's before you do anything. So, get up, deep breath, cough, get that specimen, and then go about your business.
Okay. Thank
Okay.
you.
Yeah, of course. Um, okay, here's what I was. Okay. Of a term I wanted you to be familiar with is basically a critical value. Do you guys know what a critical value? Let's say I'm doing a test and I get a critical value. Somebody know what that is? Can you tell me? In like one or two words. We gotta get to call to an MA. LOL. Oh, yes, yes. I think I see what you're saying. Basically, if you get a critical value on any kind of test, it's something. Yes, high importance. There you go, Bonnie. That's perfect. It's basically a critical value is something that's outside. Of course, it's outside of the reference range, but it's so far outside of the reference range that it could be life threatening. So, critical value, potentially life threatening. So, this is not something that we sit on, right? It's not something like we're like, well, the doctor will be back in a couple of hours. I'll just wait and tell him then. No, a critical value is something that you report immediately. And what else are you going to do after you report it, ladies, to protect yourself? Exactly.
Document.
Document. Perfect. Exactly. So I'm going to call, let's say I get a critical value, whatever it might be. Hey, doc, I'm letting you know Mr. Smith has a critical value of XYZ. I want to make sure you know about it right away. I just got the results. Okay, great. Bye. So I'm going to type in, told Dr. Smith on 3/23 at 12:37 p.m. reported critical value, something like that. So I want to document who I told, when I told them, so date and time. Okay. Um, let's see what else. Some other things that might come up as point of care testing depending on where you work. And I'm not going to go into details about these tests, just to give you an idea of some other things that might be point of care. Different electrolytes can be a point of care testing, like sodium, potassium, magnesium chloride. Different hematology studies like hematocrit and hemoglobin, um, glucose, of course. Cholesterol, there's point of care testing for cholesterol, like your triglycerides, total cholesterol, your HDL and LDL, certain blood coagulation studies like PT-INR. So those are just some examples of different point of care testing that we may do depending where we work, and just important to understand the reference range if we were ever to get a critical value, and then of course, instructions, preparation, collection, transport, and handling instructions, and making sure to follow those and ask questions if we need clarification. Never be afraid to ask questions. Okay, so let's talk a little bit about, oh, here's so much. Let's talk a little bit about, I want to get through it all, special blood collections. So this is like blood smears, blood cultures, blood donations. Blood smears, I really want you to review these in your text, the images, because it's so much easier to visualize. And did you get to the chapter yet where you read about the blood smears? Okay, so you probably know what I mean. It's a lot easier to visualize these. And you can ask, so once you've taken a look at these, and I'm going to give you a few review things here in a second, but if you have any questions on these, this is going to be a great one to ask in the skills lab because it's just easier to demonstrate or show in person. So review the images in your text. Let's see. So peripheral blood smear. This is also called blood films. This is a procedure that consists of that thin layer of blood that's smeared on the microscope slide, right? And then it's stained so they can examine what they're more easily see and view and examine what they're looking at on that slide and in that blood. And I'll talk a few more things about what they're going to be looking for. But a blood smear is a test. That basically you're looking at, you can look at the size, the shape, you can actually manually count the number of different cells. So you're actually visually and manually looking at and counting and assessing these cells, right? You can use either venous blood or capillary blood for a blood smear. You can actually even directly collect from the patient, like you could drip directly onto the slide. The thing to remember about blood smears is they have to be prepared within 1 hour of collection. If it's especially if it's obtained from an EDTA tube, and this has to do with, of course, clotting and things. Um, as you're reading your text and review, it's the method that we use to do the smears is called the wedge method. You do want to make sure that the frosted side of the glass is facing up, and don't put the blood directly on that frosted end. You're not going to be able to see the sample. It's also usually where it's used to label is that frosted end. So make sure to avoid that as well. Most of the drop of blood, when you do drop a blood on a slide for a blood smear, it's going to be, as you're doing that smear with that wedge method, it will be thicker at the end that we initially dropped it, right? And then it gets thinner as we go, and it's got to have that, for it to be done properly, you've got to have that feathered, kind of slightly rounded tail at the end. Blood smears also should not touch the edges of the slide. You want to keep it within that slide and not go all the way to the edges. So as you can see, this is something that's, again, easier to visualize images of, or actually when you do hands-on with. And also there are also machines that do these for you, but also important to know as a phlebotomist, at least have a basic understanding of how this is done. And some of the considerations, like not getting it to the very edge and not having it on the frosted side, those types of things. Blood cultures. Let's talk about blood cultures a little bit. I think I did mention this in the last lecture. Does anybody remember one of the most common reasons that we do blood cultures? That might be a very kind of random question to pull out of nowhere, but do either one of you happen to remember one of the most common reasons we do blood cultures? You want to tell us, Bonnie, if you remember? I think that yes was for the question I just asked. I looked away for a second. That's okay. You two are getting picked on because you're the only ones here today live. So a lot of times where you do blood cultures for a fever of unknown origin, okay? You might see that abbreviated to FUO, fever of unknown origin. So blood is sterile. If there's a pathogen in it, not good. When you hear somebody say that they're septic, this is what we're talking about. When we've got a pathogen in our blood, it's life-threatening. It needs to be addressed right away. Blood cultures, we have aerobic and anaerobic, right? 2 bottles. Um, so aerobic, again, think of microorganisms that need air. They thrive with air. Anaerobic, these are used to collect and grow specimens that thrive and live in an airless environment. Chlorhexidine gluconate. You guys, if you work in healthcare, you've seen chlorhexidine probably before, but this is an antiseptic, antibacterial agent that often is used to clean. To this the area where we're going to draw blood cultures from. It creates a sterile space for us. Something to remember about blood cultures. We also often draw more than one. And so a lot of times you'll see an order that says blood cultures times two. So if I get for blood cultures times two, how many bottles am I drawing? Four, actually, because each blood culture um, draw that we do is 2 bottles. So if I do blood cultures times 2, I've got 4 bottles total to draw. Now this is, and I talk about this in the lecture and it's also in your text a little bit, but this is done, blood cultures times 2 is done to avoid false negatives when we're doing blood cultures. You may see specific instructions like draw blood cultures times 2 from a different location 30 minutes apart, for example. So it's going to be really important when we do draw blood cultures that we're documenting not only the date and time, but also the location of where we drew it from. Blood culture is another thing to point out or remind you of is that we have to draw the correct amount. You can't draw too much or too little. There's going to be lines that mark it. You want to get it right at the level that it's supposed to be at. Let's see. I think that was the main things I wanted to remind. I mean, we talked a little bit about blood cultures last week when we were talking about order of draw, but I just wanted to point out a couple of those other things again or remind you of those things. I don't think I mentioned that a lot of times you get blood cultures times 2, for example. So that was something to point out. Blood donations. I mentioned we were going to talk a little bit about blood donations. So a blood bank, excuse me, is a place where blood is collected, right? It's collected, but it's also typed. It's separated into its different components. They store it and they prepare it there for transfusion. It could be blood banks can be like freestanding, separate facilities, or they could be part of a larger facility or laboratory or hospital. A lot of phlebotomists work in the blood bank. You may also do things in a blood bank called therapeutic phlebotomy, and we'll talk about that in a minute. Um, so a couple words I want you to be. I'm going to kind of give you a little vocabulary list here. So I want to make sure you're familiar with these terms to review. So autologous transfusion. That's when a patient donates their own blood to be used in the future. So for example, and certain criteria have to be met for you to be able to do that. But let's say I know I have a big surgery coming up. Well, that they're expecting a decent, significant amount of blood loss. Well, if I know that in advance and I meet the criteria to donate my own blood for future use, I may choose to do that, right? Um, Blood banks also, like I mentioned, therapeutic phlebotomy. This is the intentional removal of blood to either the most common two are polycythemia vera and hemochromatosis. So I want you to be familiar with those. Those are two reasons that we may do therapeutic phlebotomy. Polycythemia vera is when we have a high red blood cell count. You may hear this referred to as our blood is too thick, right? This is actually related to a gene mutation that alters our red blood cell production. So they're going to remove some of that red blood cell, or they're going to lower that red blood cell count so the blood's not so thick, okay? Hemochromatosis, this is when our iron levels are too high. So they're processing the blood to remove some of that get that iron level back down. Does that make sense with those two? I feel like I kind of stumbled a little bit when I was explaining those, but does that make sense? Okay. Um, what else do I want you guys to know about here? Apheresis. This is the removal of blood plasma from the patient's body. It's a process that basically separates our blood into plasma and cells, and then the cells get returned back to the body. And then that plasma is kept. You've heard of like plasma donations, right? So this is that process. Um, let's see. And this is a basically this is a piece of equipment, an instrument that is essentially a centrifuge that separates, just like when we talked about separating into the different components, right? This is this process that happens where it's withdrawn, the centrifuge happens, and then the blood that they're not trying to pull apart, the non-plasma parts of the blood, are transfused right back into the patient. So you're basically hooked up to this machine. So blood comes out, centrifuges it, gets the plasma that it wants, and then recirculates the blood back to us. Okay. Um, okay. So again, those were some terms I want you to be familiar with. We've got autologous transfusion, polycythemia vera, hemochromatosis, and apheresis. So just I would go in your textbook and maybe just review those little sections there just to make sure that you feel comfortable and understand what those mean. There are, like I mentioned, some parameters for autologous blood donation, but there's also just parameters for blood donation in general, right? And these are designed to help keep the donor safe as well. Um, Not only the recipient, but the donor. In a lot of cases, you have to be 16 or older, you have to weigh at least 110 pounds, and you can't donate any closer than 56 days apart. Um, oh, I forgot one other word I wanted you guys to know: iatrogenic anemia. I feel like I mentioned this, or maybe I'm just remembering my lecture and it's all getting mushed together. Iatrogenic anemia is caused by blood loss due to either repeated venipuncture in a short amount of time or taking out too much blood at one time, basically greater than 10% of the patient's total blood volume. As a phlebotomist, if we're working on a unit where we're repeatedly doing this, like, venipunctures over and over again on the same person in a short amount of time, or we have a concern, let's say for a small patient or pediatric patient, that, wow, they're asking me to draw a lot of blood at one time. This is something that as phlebotomists, we are advocating for our patients, right? We need to bring up this concern and let the provider know that we are, has this been crossed anybody's mind, right? So we always are advocating for our patients. Let's talk a little bit about processing specimens. Yeah, I think we're good. So I know we only have about 10 minutes left. Processing specimens. It's important, or there's a lot of important steps. Yeah, go ahead, Bonnie. Not on this coming test, Bonnie, you don't have to, but it is something that you should be reviewing in skills lab, and then you may see that pop up on your NHA certification exam. And you know what? Now that I'm saying that, I will double check that, Bonnie. I don't want to lie to you. I'm almost certain that's not on there. You know what, Bonnie? So I'll check. I don't want to waste time in here, but I will check and let you know if I need to. I'm going to send myself an email though, so I don't forget. Let me send that email. Oh. Okay. I sent myself a reminder, so I'll check on that. And then if you guys do need to know it, I'll send a course announcement. But I'm pretty sure we set it up so that you didn't have to do it on this test because you would practice it in class first. Okay. So there's a lot of steps that we have to follow as phlebotomists in the, drawing, handling, and transporting of specimens. Some of these things that we may or may not be responsible for depends on where we work and what our exact position and role is. Mixing samples, creating aliquots, adding diluents, centrifuging, packaging and labeling, following thermal and light sensitivity procedures, all that sort of stuff. So let's talk a little bit about each one of those, okay? So mixing samples. This is part of processing. It's one of the first things that we do as after we draw the blood, right? When I talk about mixing samples, that's the inversions that we do, right? Again, we're not shaking, we're not doing this. It's the gentle inversion of our tubes. We're mixing the sample. Creating aliquots. So this, once a sample has gone through a centrifuge and it's divided into its parts, now we need to create aliquots, or dividing that specimen into the smaller portions. So I've got my test tube, it's been centrifuged, it's divided into parts. Now I need to get out and put into different containers the different parts of that specimen. So that's the creating the aliquots, and that's, let me type that in. An E. Oh, it doesn't have an E. I'm always so bad about that. There we go. Okay. So diluents. A diluent is basically a solution, usually like a water or saline, that is used to reduce the concentration of a specimen. We may be responsible for doing that. Centrifuging, of course, you guys are familiar with by now. That's the spinning at high speeds that separates our sample into its components for further testing. Packaging and labeling specimens in the appropriate biohazard bags is part of what we do. Following thermal and light sensitivity procedures. There are two terms that NHA has that are not in your text. I'm going to tell you right now. Thermolabile and photosensitivity. Okay. So thermolabile is something that's sensitive to high temperatures, and photosensitivity is when something has a normal reaction or a change as a result of being exposed to light. So what is the most common thing we do for specimens that need to be protected from light? If specimen needs to be protected from light, what do we do? Go ahead. Wrap it. Yeah, but what do we wrap it in? Do you remember?
It seems like I heard aluminum foil or something like that.
Yeah, no, that's exactly right, Bonnie. Yeah, a lot of times we're just wrapping it in aluminum foil. Now, some tubes come in that amber color, which helps for photosensitive specimens. But most often, you see those amber tubes in our microtube collection sets. Just our standard evacuated tube sets, we're usually wrapping in foil. Let's see. So bilirubin and folate are two common examples. So remember these that are photosensitive and need to be wrapped in foil or protected from light. Um, oh, Ammonia and lactic acid are two common examples of specimens that we need to keep cool in a slurry. Okay, ammonia and lactic acid keep cool in a slurry. Um, Bilirubin and folate protect from light with the foil. Now, when I say a slurry, what is that? What is a slurry?
Isn't it a mixture of ice and water?
Exactly. Yeah. And the reason we do the mixture of ice and water is because if it was ice, it basically, well, put another way, the mixture of ice and slurry prevents things from freezing. And it also allows it to cool evenly. Instead of if it was all ice, it might freeze or it might only get cool on one end and not the other. So the slurry is really important. Um, Oh, okay. Couple other little random FYIs just to review. Blood gas tests can be stored at room temperature for 15 to 30 minutes. And then if you have them at room temperature for, if you're getting close to that 30 minutes, 15 to 30 minutes, you do have to put blood gases into a slurry after that. And then only up to an hour. Then those tests have got to be run. So these are just things that you'll get familiar with the more you do them, obviously. Coagulation studies need to be run within an hour from collection. The one exception to this is PT or prothrombin time. That can actually stay at room temperature for up to 24 hours. So again, just a few little tidbits here, some of these things that you're going to become more comfortable with and more familiar with as you go along. Drug testing. I want to mention that because I know we're getting to the end here. And drug testing, there were a couple things in particular that the NHA mentions about drug testing that they want you to know, and that's blood doping or the use of erythropoietin. So, drug testing is done for, just you get hired for a new job or, hopefully it never happens to you, but you're behaving inappropriately at work and it's a repetitive thing and there's a for cause and they're wondering if someone's doing something. There's also sports related drug testing that analyzes either blood or urine, and that is where I was mentioning the blood doping or the use of erythropoietin. So I want to mention those. So blood doping, that's when you inject blood cells or blood substitutes into yourself to create or increase endurance. It boosts the bloodstream of its oxygen carrying capacity, which is what makes you have that greater endurance. Erythropoietin, is a medication that is often given to chemotherapy patients who have cancer. And it actually also boosts the production of red blood cells, therefore, again, increasing endurance. So both of these can be used illegally in sports related, to increase endurance and get better performance. Bonnie, did you have a question or a comment?
Yeah, the
Oh, spell
last
it?
word. Yeah.
Yeah. Erythropo. No, give me. I must admit, spelling is not my strong suit. Oh, I forgot an O. After the R, there's an O. Erythropoietin. Sorry. You got it though? Erythropoietin. Add an R. Add an O in there. And I know it's one. I know you two probably have to get back to work, but if you're able to, I mean, maybe need just a few more minutes. I'm going to tell you about what a chain of custody is and then some inborn errors of metabolism. Chain of custody, I'm talking about this right now because it has to do a lot with drug testing, for example. I mean, there's other things that chain of custody is used for, but chain of custody, and this is the definition straight from NHA, is the chronological documentation or paper trail showing the acquisition, custody, control, transfer, analysis, and disposition of specimens that provide evidence. I know that's a long definition. You don't have to memorize it, but I just want you to have that definition. Basically, what that's saying is from the moment that specimen is being drawn, even the preparation leading to it, to the moment it is provided as evidence, the chain of custody accounts for its, how can I say, its whereabouts, its handling, its everything, its safety, its security. If any little bit, any little thing is broken in the chain of custody, you cannot use that as evidence. So let's say, there's a rape case, right? And they are able, the person who is being accused is able, their team is able to show that the chain of custody was broken somewhere, even if that piece of evidence would have proven that person guilty or innocent. If that chain of custody is broken, it's thrown out. So we as phlebotomists have a role in the chain of custody. So it's really important that we understand how important that is, and know how to follow the policy, the procedure, the protocol for that. All right, the last thing, and I know you guys got to run. Inborn errors of metabolism. I'm going to give you a quick down and dirty vocab, spit out the definition, but basically you'll have the list of vocab words. These are just things you just need to be familiar with. Cystic fibrosis, okay? That's mucus secretions that accumulate in various organs. Hypothyroidism. And again, these inborn errors in metabolism. Hypothyroidism, that's when our thyroid does not function properly. It's a decrease in the thyroid function. PKU, this is phenylketonuria. This is a metabolic genetic disorder characterized by a deficiency in our hepatic enzyme, PKU, or phenylalanine hydroxylase. So PKU can cause permanent intellectual disability. This is one of those ones that you do the little heel test they're testing for newborns. It can cause psychiatric disorders, seizures, delayed development, behavioral problems, eczema. Basically, this phenylalanine is found in most foods, and if it's not broken down, it gets to the levels become toxic in our body in an infancy. So it can cause damage to the infant, to brain damage, if it becomes toxic. So that's why they test for it immediately. Galactosemia. This is a lack of an enzyme that breaks down galactose, galactosemia. Galactose is a milk sugar. It breaks that into glucose. So if this happens in, let's say, a baby, and it's not treated, that poor little baby can actually starve to death because they're not able to break down the galactose like they should. Biotinidase deficiency. And I can write these out. I'll type them in the chat in a minute. This is a deficiency of the enzyme that breaks down biotin. Sickle cell disease, a lot of you have heard of this. Abnormal hemoglobin structure, looks like a moon instead of a donut. This is when we use those bloods, and like I was saying, this is what we're testing for when we do the blood spot paper on infants. A couple things to remember about that blood spot paper, and then this is the last thing. Blood is only applied to one side of the form, not both. You actually avoid, I know I'm doing this, but you actually avoid touching the skin. You want it to drip. You avoid blotting or attempting to like use several drops to get that circle full. You really just want to get it in one good solid drop. If you do too many drops, it can actually cause serum rings, and that alters the test. It won't be usable. Some other reasons why the blood spot paper is rejected, if the circles are oversaturated, or if they're not filled completely, right? It's got to be like perfect. If the form is expired, so always check your form first. If the specimen has been contaminated in some way, if you did not allow the specimen to dry thoroughly and then you packaged it, or if you have those serum rings that I was just talking about. So if you work in a facility where you're doing the infant blood spot papers, just things to keep in mind, and you do want to be familiar with these for this part. So you guys are welcome. Well, first of all, if you have any questions, let me know. I will type a quick list of those vocab words so that everybody will have them on here. These inborn errors of metabolism, so that you'll have them. But otherwise, you two, I know you got to get back to work. If you have any questions, let me know. If not, you are free to go. You are very welcome. I hope you guys have a, yeah, go ahead.
I was just going to say, the only question that I thought of, and I don't know if you know the answer of it, but I just kind of thought of it as you were going over the vocabulary for like polycythemia and hematomacrosis. So I actually worked at the Blood Connection as a scheduler.
Oh, yeah.
And we would have people come in who would donate, but they, like, that blood, like, can't be used. Like
If they had, tell me if they had which one again, go back up a little bit.
Like if they had like polycythemia or hematomacrosis.
Yeah.
So like it was like marked like in the system, like with the Blood Connection, like that they only like came in to donate that, like because their iron levels were too high.
Right.
So like what is like done with that blood?
Ooh. I don't know. You're right. I don't know the answer to that. I wonder if there's some other uses. I'm not sure. But first of all, now that you've asked that question, I want to look it up so I know the answer. But also, Michelle J, she worked in, I forget exactly where it was, but she probably knows the answer to that question.
Okay.
I would ask her in class, or I can actually, I'll send her an email today too and ask her, and then we'll all know the answer because I'm not sure. But that's a great question. Yeah.
Okay. Yeah, I just, as you were going over that, I just thought about it because they would come in and like they would only be able to donate that. So they just donated, because their levels were too high. But
Exactly.
then, like, I don't know, like, what's done with that blood. Like, is it just discarded or are there other uses for it?
That's a great question. I'm writing it right now so I don't forget to ask. All right, so I will ask Michelle, since I'll talk to her before you guys probably will, and I will let you guys know what she says. And if she doesn't know for some reason, then I'll look it up. Any other questions?
That was the only question that I thought of.
Okay, awesome.
I don't think so.
All right,
Thank
well, I'm
you.
typing out this list real quick, and then you guys are all set, so I'll talk to you guys soon. Just let me know if you have any questions.
Perfect. Thank you.
All right, you're welcome. Right. And there is the list. So you guys are free to go. I'll turn this recording off and then everybody can listen. Anybody, if you come up with any questions, of course, ask myself or Michelle, and we are happy to help. You are very welcome.